My name is Martin Ugander from the Department of Clinical Physiology, and on behalf of the department here at the Karolinska Institute, I'd like to welcome today's speaker, Dr. Todd Schlegel. And Todd has a background with a bachelor's degree in biology from the University of Minnesota, where he also attended medical school, and then went on to the Mayo Clinic for specialization training in internal medicine. But Todd chose a somewhat different path than the conventional clinical path, and shortly after completing training in internal medicine, went on to NASA's Johnson Space Center in Houston, where he worked for 20 years as a medical officer and senior researcher, where he did a lot of the development that he's going to be talking about today within advanced ECG. And it's a real treat to have with us today the physician that they called when they said, Houston, we have a problem. So Todd would be Houston in that setting. Without further ado, welcome Todd, and we look forward to this expose of state-of-the-art in advanced ECG, detecting more than meets the eye. Welcome.
Thanks very much, Dr. Janet, for that nice introduction. And if only I could solve those problems that Houston often has. As Martin mentioned, I am now actually a member for the last year of the Department of Clinical Physiology at Karolinska, sort of a courtesy appointment here. But I currently live in Switzerland and have formed a small company to commercialize some of the things I'm going to talk about. So the title of the presentation is State of the Art in Advanced ECG Detecting More Than Meets the Eye. So in terms of a general outline, we're going to talk about what is advanced ECG, the measures or parameters that contribute to it, how we can use advanced ECG to distinguish health from disease, and also different diseases from one another. And we'll look at some case examples as well. So what is advanced ECG, or what is the need for it? Why do we care? Most of you in this room know that conventional ECG has a number of limitations of a resting 12-lead ECG. So, for example, it has very poor sensitivity and specificity for coronary artery disease or left ventricular hypertrophy if you're using an imaging gold standard. So this is a problem. Maybe we can get something more out of the conventional ECG than what we're doing. Moreover, there are a large number of advanced ECG parameters with proven clinical benefit in the literature. So they're out there, they just haven't been translated into clinical practice, but they really need to be. So these are sort of the two main drivers. In terms of what is advanced ECG, we have sort of a mantra, which is to collect once and then analyze everything of value. So we can take the raw digital data file that's behind the 12-lead ECG and throw a number of different advanced software techniques at it. So basically, this just involves data acquisition first. You have to collect the data, store it, and then comprehensive analysis software suite. We're going to go over some of the different applications that constitute that, and then an A-ECG reference database that has accompanying gold standard imaging results for statistical comparison. So that's really a big part of it, sort of big data in the background, having lots of patients and healthy subjects, conventional ECGs analyzed for advanced ECG, then also having gold standard imaging results in a big database, and then you're going to refer new patients to that big database to figure out what they have. And that's what we're doing with generation of A-ECG disease scores. Hopefully this is still working. There we go. So what are some of the measures that are contributing to A-ECG as we currently practice it? Certainly one has to start with the conventional 12-lead ECG. That's the sort of the bread and butter of ECG. So most of the parameters that clinicians look at, we're going to obtain Electrocardiography as well. In this case, we're going to typically derive it from the 12-lead ECG. Techniques called T-wave and QRS wave complexity, which are newer techniques in the literature that I'll describe. High-frequency QRS and late potentials, which are signal averaging techniques that involve also some digital filtering. Late potentials is one that's actually been commercialized since the 70s, but it's not one of the stronger techniques, it turns out. It tends to be displaced by some of these others. Advanced P-wave analysis, for those of you who are interested in things like prediction of atrial fibrillation, someone who's in normal sinus rhythm. We can do lots with the P-wave to help predict that. And then finally, beat-to-beat RDAR interval variability and QT interval variability. The RR interval variability being better known as heart rate variability. These techniques tend to require a slightly longer recording because you're getting variability measurement and sort of a minimum of 4 to 5 minutes, whereas most of the rest can be obtained with a shorter ECG. So let's just talk, kind of go through these quickly. The conventional 12-lead ECG parameters, basically all of your conventional intervals, axes, voltages, and combinations of conventional ECG parameters. So let's say a Cornell voltage or a Cornell voltage area when you look at the QRS interval as well, Schlegel, those kinds of things. The software is automatically generating all those as well. If we move on to vectorcardiography, this gets a little bit more exciting. What we do is we take the 12-lead ECG in this case and we transform it. There's a number of different transforms one can use, but essentially after the transformation, one can derive the frank X, Y, and Z leads, the classic leads from vectorcardiography that are orthogonal to one another. And then one can do lots of different things once one has the VCG. So the whole world of 1950s through 1970s, VCG opens up once again. And all of the power, the diagnostic and prognostic power that is in those parameters. So we prefer the CORS transform, which is just population regression-based transformation. This is just an example of kind of what I'm looking at when I'm looking at the derived VCG. We have a number of different parameters, literally hundreds coming from the VCG, and these contribute a big slice to our overall diagnostic and prognostic power. If we look at just one of those techniques, this is the spatial QRST angle. And so what we're looking at here, once we derive the frank leads, we can then transform things into three-dimensional space. And as an example, this is the QRS loop here. It looks like my red dot isn't working real well, but if you look on the left side, the QRS loop is the main loop, and then you can see the vector direction of the main loop. And the T loop is this smaller loop here. And you're looking at the angle between the two, which is the spatial QRST angle. You can see this is the right side of the patient, the left side of the patient, and anterior posterior. So this is a normal angle, right around 60 degrees in this person. And over here we have an abnormal angle, which is obtuse rather than acute, somewhere around 111 degrees. So the spatial QRST angle is a very important parameter. It has a lot of diagnostic power. In fact, it has more prognostic value for cardiac death than any classic cardiovascular risk factor in the literature. So it's more important than, say, having diabetes or having hypertension. It's more predictive of risk going forward, having an increased spatial QRST angle. Also, it's more prognostic for cardiac death than even dopamine stress echo in some of the literature. And it's the best predictor of life-saving ICD discharges in patients with known ischemic cardiomyopathy. So if you have a low EF and you measure a spatial QRST angle, what this paper showed was that if your angle is less than about 110 or so, the chances that you're going to have an appropriate shock from an ICD are very low. So there's an argument that you need not even implant, even if EF is low, if the angle is low as well. So a very important prognostic parameter. We'll move on to T-wave and QRS wave complexity. So this is a little bit more mathematically complex if you've never seen it before in the literature. We use a technique, it's just a mathematical technique called singular value decomposition. It has another synonym with a slightly different way of doing it called principal component analysis. Basically, it's a description of the T wave or the QRS wave in terms of eigenvalues or energy, quote unquote, and the principal components. And these are just mathematical characteristics of diagnostic interest. Bottom line is that increased QRS complexity tends to suggest a depolarization abnormality, and increased T-wave complexity tends to suggest a repolarization abnormality. If we look just at some of the nitty-gritty of it, essentially in the 12-lead ECG, you have 8 independent channels worth of information. You don't have 12, you have 8, because you're getting 2 independent channels from the limb leads, usually 1 and 2 in most machines, and you're deriving lead 3, and then AVL, AVR, AVF from the 2 limb leads also via Einthoven's equations, essentially. So the 8 independent channels are 2 of the limb leads plus all the precordial leads are independent channels as well. So those 8 channels you just push into a mathematical algorithm that's used in lots of other applications besides ECG. And what you wind up with is 8 different eigenvalues. You can see EV1 through EV8. You gave it 8, so it's going to give you back 8. But you'll notice the first eigenvalue, if you look at its size, it's a lot bigger than any single channel of ECG that you've fed into it, because it's sort of the principal component in space. You've reduced it to an eigenvalue. The second eigenvalue is perpendicular to the first. If you kind of imagine like an ellipse in two-dimensional space, the first eigenvalue would be akin to the length of the loop, and the second would be like the width of the loop. And now, the third eigenvalue is orthogonal to the first and second. Think of that as sort of like the elevation of the loop against some preferred plane. So these are all mutually orthogonal, and you can notice the diminishing energies as you go from 1 to 3. And after number 3, you really can't even see it at all, sort of below visual perception. But what happens with this technique, and especially in the T wave, where most of the diagnostic value is that in healthy people, the vast majority of the energy should be in that first eigenvalue. As one gets disease or greater complexity in the T wave, so if you see kind of non-specific T wave changes on a conventional ECG, typically what's happening is you're pushing those energies from EV1 or 2 downstream into EV3, EV4, etc. So one can measure ratios here and determine the abnormality or additional complexity of the T wave, where essentially you can't explain the T wave any longer, it's just the dipole. The dipole are the first 3 eigenvalues. Everything past the first 3 are the so-called non-dipolar components because they're outside of 3D space as we visualize them. So that's T-wave complexity. Why do we care? Because again, like with the angle, T-wave complexity in a number of studies has predicted cardiovascular death. QRS complexity also predicts incident heart failure and also cardiovascular death. T-wave and QRS complexity in our own studies indicate or can indicate reduced LV ejection fraction or the presence of left ventricular systolic dysfunction, especially when they're severe. All right, we'll move on to the next type of techniques that contributes to advanced ECG, and this is sort of the signal averaging plus digital filtering style of techniques. Many of you, if you have any cardiovascular background, have heard of late potentials because those are used clinically, although they're sort of fading out now. Let's look at high-frequency QRS. So in this technique, what we're doing is we're signal averaging first. Up here you see the conventional tracing, and this is you can see it's thousands of microvolts, so about a millivolt for your voltage, or half a millivolt in this case. And this is in the standard frequency. So most of what you're seeing out of conventional ECG is less than 100 hertz. That's what your eye can make out. It's a predominant higher voltage frequency. But if we take the QRS, we signal average it, and we filter it, and this requires a little bit higher fidelity ECG where you have a higher low pass, which lets the higher frequencies in. So a typical machine, probably even in this institution, wouldn't do that. You would knock out those higher frequencies just by the way the filters are set up. But if you have a higher fidelity ECG, you signal average, you notice then if you filter between 150 and 250 hertz, that you end up with a signal that's in the 10 microvolt range, and that's sort of the residual. You can think of it as sort of like the little excursions that are occurring inside the conventional QRS that you can't make out with the naked eye. If we look at this case, this is a case of during a PCI and a balloon inflation. You'll notice that during the inflation in this case, there wasn't much change in the conventional ECG complex, but if we go down and look at the high-frequency QRS complex, we see a diminution in voltage overall, and we also see kind of a spreading out of the signal, producing some reduced amplitude zones. So this is something that's useful for detection of ischemia, and it can be helpful even in arresting ECG as well. It's certainly autonomically influenced as well. Okay. Let's see if I can. There we go. So the next technique in the same general category is late potential. Some of you might be more familiar with this. In this technique, again, we're doing something very similar to high-frequency QRS, but now instead of between 150 and 250 hertz, we're filtering from 40 to 250 hertz. So we're letting through some additional higher voltage signals in our filter. And you'll notice here then that we're starting with the vector magnitude, so square root of the sum of the squares of x, y, and z. You get a vector magnitude. So this is the QRS as filtered. So this is in milliseconds, just this filtered QRS signal average complex. And we can see that our voltages here are higher than they were with HF QRS. Now we're in the 100 microvolt range rather than 10. And in this technique, typically what one is looking for are these so-called late potentials toward the end of the filtered QRS vector magnitude. And there are stereotyped parameters that one looks for, how much energy is here, and how much occurs in the last 40 milliseconds, and so forth. So these techniques were used to identify risk for ventricular tachycardia. It's still used, even like, for example, in ARVC criteria. This is one of the techniques that's still employed. But it's increasingly being less utilized because, again, it has a little less diagnostic power than some of the newer techniques. Let's move on to P-wave analysis. And here, again, it's the same thing. Now we're getting the frank XYZ lead P waves, in this case, to look at P wave morphology. And there are a number of studies that look at morphology and have determined that changes in the morphology over the appearance of the derived frank lead P wave can be helpful in predicting future atrial fibrillation and other conditions. Here, this is just the P wave vector magnitude, and then the filtered P wave, just like before with the late potential, same filter we can use, or different filters. So lots in the literature here showing that these things help to predict AFib, and also, not only that, but also heart failure death. So there's certainly a physiologic tie-in, maybe correlation, maybe to some degree causation as well, of abnormalities in the P wave and supposed ventricular events. If we move on to beat-to-beat, R-to-R interval, and QT interval variability, this is a technique where you're just looking from one R-to-R interval to the next. Many of you may have seen this. A lot of Holters have implemented R-to-R interval variability within them. And typically, boy, it's touchy. Where are we? Typically, what you see here is a tachygram. So we're just, in this case, it's beats per minute against time in seconds. Typically, it's better plotted using an R-to-R interval. If we look down here, we see what's called a Poincaré plot, where we have the R-to-R interval plotted against the next R-to-R interval in the sequence. And you end up with sort of a blob that looks like this. And you can fit an ellipse to the blob and measure its standard deviation lengthwise and widthwise. And those are useful parameters in the so-called time domain of R-to-R interval variability, help you to quantify vagal cardiac activity or modulation. And we can see some of those parameters here. This is just a simple histogram where you can do some fits to it and derive a number of parameters useful for HRV as well. You can move from the simpler time domain into the so-called frequency domain. And typically, then, you're looking at a power spectrum. There are different ways to do it. But essentially, in the frequency domain, usually folks are using a fast Fourier transform or an autoregressive type analysis. We actually prefer another technique that's called the Loom periodogram that comes from astrophysics. And it gives us a little bit more robustness to things like premature ventricular contractions when they occur. So ectopy is something we can fairly easily and automatically eliminate when we use Loom, as opposed to these more traditional ways of doing the power spectrum. So you're looking at the power within any given frequency. Typically, this is the 0.1 hertz range is typically the sort of the baroreflex frequency, and the breathing frequency is usually right around in here, 0.2 to 0.25, 0.3 hertz. So this is especially vagally modulated. This is sort of mixed vagal sympathetic. Why do we care about this? And again, we know that diminished power spectral power identifies the risk for death in heart failure, and nice paper in Circulation. So real low levels of RR variability as quantified by this technique in heart failure patients is a strong predictor of death. Even stronger is to bring in QT interval variability. So now we're not just looking at R-to-R interval variability, we're looking at the change from beat to beat from the beginning of the QRS to the end of the T, the QT interval from beat to beat. And unlike with heart rate variability, where typically a young person tends to have high-ish heart rate variability, and as you age, you lose that heart rate variability, sort of loss of the suppleness of the autonomic nervous system with aging. In QT variability, it's the opposite way. The more QT variability you have in light of your underlying heart rate variability, the worse. Okay? It reflects an increased temporal repolarization heterogeneity. It's a long mouthful, but that's essentially what it is. So what we're doing with this technique, this is the RR variability here in red. You can see this scale here in milliseconds. This is the underlying or associated QT variability here. So we're really just indexing the QT variability back to the RR variability. In a healthy patient, they're almost superimposable. So the heart rate variability is really driving the QT variability. In disease, those things start to get dissociated. There's a whole host of literature on prediction of cardiac death, sudden cardiac death and events from QT variability. It's one of the stronger ones. I would say the two strongest single parameters are this and the spatial QRST angle in the literature. And then I'll just mention of the measures that contribute to A-ECG that we've described, certainly the conventional ECG, everything from the derived electrocardiogram that we talked about, like the angle, and almost all of T and QRS wave complexity can be derived from a mere 10-second snapshot ECG, so the typical ECG you're collecting in your clinic. The other techniques where we're doing the signal averaging, digital filtering, including in the P, or the variability techniques, obviously you need something longer than a mere 10-second ECG. So we can get that, though, with the 5-minute ECG, and certainly we can get all the rest with the 5-minute ECG if that's what's obtained. Distinguishing health from disease. So I mentioned this briefly, that we have large numbers of cases in our underlying large database with thousands of patients and healthy subjects that have verified, boy, I keep pressing the wrong thing here, that have verified health or disease, and what type of disease is also annotated in the database. So we have, based on this, and the healthy subjects, we've generated normal ranges for age and gender for all of the parameters. And we have then also, using statistics, drawn up multivariate disease scores that utilize some portion, usually just a handful of the 400 plus parameters that are available to us, so we can remain statistically legitimate and not overfit things. And so the most common way to do this, and sort of the easiest or most straightforward, is just use logistic regression. You create a handful of parameters that sort of act as a team and help you with the diagnosis of the given condition in your score. Or we can get fancier and use statistical pattern recognition, where now we're entering into the domain of things like discriminant analysis and the principal component analysis, neural nets, etc. So one can kind of pick and choose what pattern recognition technique one prefers. At this point, we actually have individual advanced ECG scores for all the conditions listed here. So coronary disease, including microvascular disease, hypertrophic cardiomyopathy, ischemic cardiomyopathy, non-ischemic cardiomyopathy, what we prefer to call left ventricular electrical remodeling as opposed to left ventricular hypertrophy, because we're really looking at an electrical phenomenon if we're talking ECG. And also that electrical dysfunction that tends to be associated with mechanical reduced left ventricular ejection fraction. We also, if someone is gauged to be healthy in sort of the initial analyses, another thing we can do is we can calculate the so-called heart age or electrocardiographic age and compare that to the given person's true chronological age to sort of see how they're doing. So it's kind of for the worried well in terms of facilitating the diminution of risk factors and improved lifestyle and so forth. We also have scores for long QT syndrome. So for example, a score that will detect a genetic long QT, even though the QTC interval on the conventional 12-minute ECG is normal. So we know that there are other characteristics that we look for in the advanced ECG in that genetic condition. As an example, so in one of our publications, if we take the conventional ECG and pool every single important criterion from the conventional ECG, and we just look for disease in general, which could include coronary disease, left ventricular hypertrophy, any of the cardiomyopathies, we can see if you're meticulous about the conventional ECG, you can get this close, 78% and 85%. But the problem is most doctors don't have the time or the inclination to be so meticulous about a conventional 12-minute ECG. If we throw our A-ECG disease scoring at it, you can see how we bump both sensitivity and specificity. This is just for sort of disease in general. We also have some other scores in development. So for example, for non-ST segment elevation MI, if you have a STEMI, you don't need advanced ECG, it's in your face. But in the emergency department, if you are worried about someone possibly having a non-STEMI or unstable angina, we can help with that. So getting a better electrical test that will help out your troponins and so forth. We have scores for budding scores for rhythmogenic right ventricular cardiomyopathy. I talked a little bit about risk scores for atrial fibrillation that hinge on P-wave parameters. Also, risk for sudden cardiac death. I mentioned the spatial curiosity angle and QT interval variability are very good parameters for that. So those fall into that score. And then finally, in people with left bundle branch blocks, the question of whether or not to implant with the CRT is something that can also be partially answered with advanced ECG and looking at some advanced parameters in the context of left bundle. Just going to go over a few case examples next to kind of show you by example how this is being used clinically now. What I'm going to show you are 4 different patients' ECGs, and most of them will be essentially normal. There may be a non-specific abnormality, which I'll point out. And then we'll look at the advanced ECG to see how much more diagnostic power it's given us compared to the strictly conventional ECG. So here's our first case. It's an asymptomatic 34-year-old female. And I'll just give you a second to look at that. But I'll say, as you look at it, that in my view, this is a normal ECG. We can see the conventional ECG automated call says this conventional ECG is normal. And I would say the same thing. Go on to the second case, an older male now instead of a younger female. And again, the conventional ECG automated call suggests normal. And I would again concur with that. I don't see any particular abnormality there. Go to the third, 62-year-old male. Conventional ECG automated call, again, is normal. For the astute, or maybe the cardiologists in the room who do a lot of reading of ECGs, you might notice that the P-wave duration is a little long. That should be less than 120. So, and you can see maybe a little terminal negative reflection of P and V1, which can sometimes indicate that. And you also notice a Q wave, although I think in medical schools they're still teaching that an isolated Q wave in V3 doesn't mean anything necessarily. Right? So this would be often read as normal. In fact, a lot of the manufacturers don't even give you a P wave duration, so unless you have time enough to go ahead and measure that out, you might miss that anyway. All right, so sort of normal. And then the final one is 57-year-old male. Automated call for the conventional ECG is again normal, but in this one, I think we at least have poor R-wave progression. So again, a very non-specific thing on a conventional ECG. Does it mean anything? Sometimes it does. Sometimes it doesn't mean anything at all. It's a normal anatomical variant. So in this case, personally, I beg for a derived ECG because I can sort this out really quick with a derived ECG as to whether or not this is anything. We also might notice maybe a little bit of sloppiness in the T here. It's hard to tell, but maybe some non-specific T-wave change. But that's about all I see with this ECG. Borderline P duration, but it's okay. Okay, so those are the 4 conventional ECGs. Now, let's go to advanced ECG. The results, and here I'm just going to show you the results from a few techniques, kind of the more powerful ones. We'll focus in from the main screen from QT variability index. And so again, what we're looking at here in red is the R to R interval variability on a beat-to-beat basis. This is time, and this is the R to R interval in milliseconds. And over here is the delta QT interval scale for the purple. And what you'll notice in the 34-year-old female is things look pretty good. She's got good variability, and not only that, purple is very much commensurate with red, right? You can almost superimpose them. That's healthy physiology. That's what healthy QT variability looks like. If we calculate our index, this is a log index, so actually the more negative this number is, QT variability index, the more healthy the variability is. This is all in 2, by the way. And that's quite normal. If I've just pasted in her spatial mean curiosity angle, what we looked at from the derived electrocardiogram in 3D, that's 35, that's quite normal. It depends on age and gender, but if anything less than about, say, 75 in a female and 80-ish in a male is normal. It's, again, age dependent. And I've also just pasted in, this doesn't mean much to you, but it's the T-wave complexity stuff. We get those 8 eigenvalues back. Then we look at some ratios, and those are all normal. So she hasn't shifted any energies downstream in that other technique. If we go to case 2, you will notice, first off, compared to case 1, we see generally less variability, not only in the RRV, but also in the QTV. But the two are still pretty commensurate. So the QTV that's there is very commensurate with the underlying RRV. So it's not surprising to have less heart rate variability in a 69-year-old compared to a 34-year-old. We know that heart rate variability diminishes with age. So, but because of the nice, still commensurate variabilities of the two signals, we can calculate our QT variability index, which is quite normal still. And we put in the spatial Christie angle, which is 66, certainly higher than our young ladies, but it's still within normal for a male of that age. And he turns out to have normal T-wave complexity as well. So these first two cases we would call normal by advanced ECG, commensurate with the conventional ECG result. Let's move on to cases 3 and 4. So remember, this guy was our 62-year-old, and he just had the P-wave duration abnormality and a Q in 3 that may or may not mean something. And what we're seeing here now is not so great heart rate variability, and we're starting to dissociate and have a greater QT variability. It's doing its own thing. It's not being driven just by heart rate variability like it should. And so because of that, this value is abnormal for his age. It's just under normal. And so we have one abnormality so far for him. If we look at the spatial mean QRST angle, it's a little higher than the 69-year-old we just looked at, but it's still within normal, sort of upper range normal. And his T-wave complexity is okay. So this is a mishmash finding. It's like, well, it's got some abnormalities, I'm not sure. So what we're going to do is put this one on hold for a second, and we're going to let our statistics tell us, our underlying advanced ECG scores tell us if this guy's got disease or not. This last one is case 4. This was the guy who had the poor R-wave progression. Maybe we saw something in the T-wave, wasn't real obvious. And here we see sort of in-your-face disease by QT variability. And so we're seeing lots of variability in the QT, but if you look at the underlying red line, it's almost a straight line, so almost no heart rate variability, yet QTV doing its own thing. This is highly abnormal, it's not negative enough. And if we go to our spatial mean QRST angle, that's abnormal, it's pushing 100. Remember I told you that in someone with heart failure, if this is above 110 or so, the chances of having an appropriate shock are a lot higher than if it's below. So this is looking heart failure-ish to me, but he may not be a guy that's a good candidate for an ICD because his angle isn't high. Still very high, but not high enough for ICD range. And then this is just sky-high abnormal with T-wave complexity. And remember, in this guy, if I go back a couple slides, we saw this. So that T-wave complexity is picking that up and quantifying how abnormal that is in the ECG T-wave. If we then simply throw our basic scores at this, so the two scores we'll look at real quick are first just disease, no disease, and then we also have a score that helps to quantify the probability of having a low ejection fraction. So we've correlated it with that anatomical phenomenon for left ventricular systolic dysfunction. And so we can see in our 34-year-old female, she has a less than 1% probability of disease. So does our 69-year-old male. That was basically a picture of healthy aging. So those are healthy by the calls. And usually if you have a healthy score here on the basic disease score, there's no way you're going to be positive here. So those are less than 1% as well for LVSD. If we look at number 3, remember that's the one we had to put on hold because we weren't sure. We had a mishmash, some abnormal, some normal. But the automated call from the scoring is disease and probability of 98%. However, he has a fairly low probability of having a low ejection fraction, left ventricular systolic dysfunction of only 16%. Number 4, we can see was obvious disease. And not only that, the LVSD score puts him into the heart failure category with a 78% probability. So we have a good feel. Now, this isn't where it ends, though. What we can do is go to our more sophisticated statistics and look at pattern recognition, and that's what we're doing here. This is a linear discriminant analysis. So it's kind of, if you look at the axes, this is canonical 1 and canonical 2, it's akin to the eigenvalues that we talked about before from principal component analysis. So you're looking at the principal components, in this case, in two-dimensional space, plotted against another. When you do that, you end up with sort of what is the preferential space for the given condition. So this is the healthy group, this circle, that's in the underlying database, so thousands of patients. Here, this is the coronary disease group or coronary microvascular disease group. And then we have, again, anatomically proven left ventricular hypertrophy. We have hypertrophic cardiomyopathy, non-ischemic cardiomyopathy, and ischemic cardiomyopathy circles. So those are determined by the underlying database. Now we bring in the new unknowns, so those 4 patients, and we plot them in this two-dimensional space. Where does their dot end up in relation to the underlying spheres or circles? We can see there's our 34-year-old. She's clearly orbiting the healthy planet. And so is the number 2, our 69-year-old guy, but he's a little further away from the healthy planet than 1. Not surprising, he's older. And here is our guy that we weren't sure about from the advanced ECG, just looking at it, but he's been put into the coronary disease category with a 98% probability. These are the actual results here. And number 4 gets put smack into non-ischemic cardiomyopathy, despite his fairly benign ECG. And we can see number 2 actually had just a whiff of coronary disease, which isn't surprising, given that as we age, if we're 69 years of age, most of us have some whiff of coronary disease. But he's still quite within the healthy range for a 69-year-old. So that is one method of doing pattern recognition. If we then go and look at what were the actual gold standard imaging results in these people, cases 1 and 2 had normal imaging with no demonstrable disease. Case 3 was someone who actually had 2-vessel coronary disease, but a normal LVEF, consistent with everything that the advanced ECG brought forward. And case 4 was actually a heart failure patient getting tuned up in a heart failure clinic with a low ejection fraction of only 25%. So that's the kind of power, or additional power, that the advanced ECG can give you. Now, I mentioned briefly the heart age score. So this, if you're healthy, the next thing that we can do is estimate your electrocardiographic heart age and compare that to your true chronological age. There are a number of parameters that go into this. This was a paper we published with some NASA statisticians who had a lot of fun generating this. But we do put the age in, but only establishes sort of a standard deviation range of where the results should fall. If you look at things, certainly gender dependent, but many of these parameters you would have heard of, like the P-wave duration. We know, for example, the frontal plane QRS axis tends to shift leftward with age, so it wouldn't be surprising that that would be a component of the score. The frontal plane T-axis, heart rate variability, especially in the high frequency ranges, which tends to be more vaguely mediated. That's a big one in the score. We know that heart rate variability diminishes with age. Also, the voltages diminish with age. JT interval from the vectorcardiogram, spatial mean QRST angle, QT variability index, unexpected QT variability index, which I haven't explained. It's just one more QTV parameter, and one of the T-wave complexity parameters as well. So you can see a wide variety of parameters from a wide variety of techniques go into the score to get us where we want to get for good statistical prediction of electrocardiographic age. And here's what it looks like. You can do this in different ways as well. This is via discriminant, which actually is just, it's not very statistically robust, but it's kind of neat visually. We see if we just take that healthy group and separate them out by the decade of life. So we have 10s through 70s here. You can see our 34-year-old female ends up in the 30s looking, and our 69-year-old male kind of looks like he's in the 70s, but if I showed you a 3D, it's a little too messy for 3D, you would see that this is actually closer to orbiting the 60s. But the best way to do this is with Bayesian statistics, where we can get an exact ECG age. And so these are the predictions from that, and you can refer to this paper if you're interested in this. We can see this was actually a 34-year-old female, but she looks about 32 years of age. Our 69-year-old male looks about 62 years of age. So we can tell both these patients that they look younger than on ECG than their actual chronological age. Go on, continue to prosper, do what you're doing it right, we'll see you in 5 years, something like this. All right, so we've talked about what advanced ECG is, all those combinations and scores, the measures that contribute to it, and we've shown you some examples of how you can distinguish health from disease and different types of diseases from one another with advanced ECG using the case examples. And I'll just mention, because of time limitations, I can't show you lots of other neat things, which you can see through some teaching videos that I have up on our website, aecg.ch. If you can't remember this, remember spaceekg.com or spaceecg.com. It will take you to the same place. And so, for example, on there you can find examples of picking up long QT syndrome that has a normal QTC interval, hypertrophic cardiomyopathy, more run-of-the-mill left ventricular hypertrophy when it's not on the conventional ECG. So lots of other cases online for those who are interested. And that ends the talk. Thanks for your attention.
So, thank you very much, Todd. Do we have any thoughts and questions from the audience? Right?
Has your method been evaluated for patients with syncope as a risk stratification?
The short answer to that is no.
Because that would be very interesting as a kind of screening, because there are many patients
Right.
who come to the emergency department with syncope.
Right.
And probably with your method you could screen those who
Right.
are at a higher risk for
Yes.
cardiac disease.
I know that heart rate variability has been used as part of an armamentarium that includes things like BTB blood pressure variability, Valsalva maneuvers. Are you an autonomic person by any chance? Are you an autonomic medicine person? Is that are you? Oh, okay, yes. So I know in autonomic medicine they use heart rate variability, but it's part of a bigger armamentarium that also includes things like responses to Valsalva maneuvers and so forth. So. But I'm not sure to what extent we could rely only on ECG to predict it. I don't know. It's an interesting hypothesis. We would just need to do a study and look at that question specifically.
And then I have another question.
Yeah.
I didn't really understand how you calculate the eigenvalue.
Yes.
Is it kind of area under the curve of a usual ECG?
No, it's matrix math. It's matrix math, which is in many software programs like a MATLAB or a LabVIEW, you'll have a canned routine that allows you to do this. So it's an 8 by n matrix for the 8 channels, and you feed it in there, and it transforms the data into preferential space. So in what plane, essentially, is the majority of the energy? That's your first eigenvalue. And then in what plane is perpendicular to that, we have the second most amount of energy. So it's simply a mathematical function. And it's best left to the biomedical engineers or the statisticians. Go ahead. Bjorn?
Yes, maybe I was thinking that if someone here were interested in collaborating with you and evaluating these techniques for a given patient population in their workplace, how would they do that?
Yeah, let's see, I should have put an email up here. But
It's available by the site.
yeah, you can find my email by the site if you go there, or email Martin, which if that's not too much of a bother. He can just put you in touch with me by email.
But how does it work? I think
Oh,
the question applies. So, for example, if I've acquired 1,000 12-lead ECGs, and I
Right.
have them stored digitally in the hospital system, I was wondering, is there something I could get out of them? Can that analysis be done after the fact?
Sure, of course. So, and Martin and I are doing these kinds of studies now. So I think that most of the ECGs here are stored in GE Muse, right? So they have a format, it's usually an XML format. So if you have a GE Muse set of ECGs, you have an interesting question, maybe something about syncope or whatever the case may be, you can pull those ECGs out of Muse in their XML format. And typically, I guess I'm not sure what the legal is for me in de-identification, but you may need to de-identify those ECGs first, so that there's no patient identifiable information. So that takes a little bit of labor going in and knocking that HIPAA stuff out of there. And then send me the files. I can convert them and analyze them. We basically know the formats for all of the major manufacturers. So even if you don't have the preferred 5-minute ECG, we can still do the most important things from the 10-second ECG. So it's very easily done retrospectively.
But if you were to want to embark upon clinical development or research prospectively, what's necessary to acquire a 5-minute high fidelity ECG,
Right.
the kind that you prefer?
Sure. As I understand it, you guys might be switching over to Philips machines in the new hospital, right?
Yes.
So at NASA, in my clinic, I had a modern Philips 12-lead ECG machine, and I simply asked Philips if they had sort of a way to allow me to collect a 5-minute ECG, and they said, oh yeah, we do. We have this add-on software, you just have to request it on the research side, and we'll give it to you for free. So that's one way to get a 5-minute ECG.
And we have that dialogue ongoing with
With Philips, great. So that's one possibility. When I was collecting those, it stopped at 5. So that's all you could get. You couldn't get 6 or 5.5. It's 5 minutes. So if you had a lot of ectopy, it may not turn out to be a great file. But the fidelity is not optimal from Philips because they're not sampling at over 500 unless they've changed that in the rhythm. But nonetheless, we could still do everything that I talked about today from a 5-minute Philips ECG. There's just a few techniques where we like for example, high frequency QRS, we couldn't do that because their low pass filter and their hardware is too low. It knocks out everything above 150. Okay, and I need the 250 for high frequency QRS. If you want to absolutely get everything, then there are manufacturers of PC ECGs. I actually provide one with my own label, Space EKG, from it's a Hungarian company. It makes a very sophisticated and very cheap, relatively speaking, 12-lead PC-based ECG, which has a much higher sampling rate, higher fidelity, allows you to collect data for any amount of time. So that's a good piece of hardware for a dedicated study, for example, a prospective dedicated study.
And we use that
And you've got one of
selective
those as
studies,
well.
so it works fine. It's just
Yeah.
a little USB box with electrodes connected to it and into a
Or
PC.
Wi-Fi.
Or Wi-Fi that stores.
Yeah.
Any more thoughts or questions? Yeah?
Do you extrapolate everything from the conventional 12-lead ECG, or do you have machines that take special?
Right. No, everything that I talked about can be extrapolated from the stored digital file from a conventional ECG. The only exception would be if you have an ECG that only collects for 10 seconds, I can only do roughly half of what I showed you. Like variability techniques require a longer duration reporting. But some the most powerful techniques like the spatial acoustic angle, that's quite derivable from just a snapshot, what typically comes off and into an XML file in your EHR. So, but otherwise, no special equipment is required. You do it right now on the files that you have stored.
So why isn't everybody doing this?
It's a good question. I think it just takes time to penetrate, to change practice, to show how we can benefit from these techniques and benefit patients. Oftentimes, avoid unnecessary testing. I have some really great examples of sort of bad so-called LDL voltage. Looks like LVH in an older person. And so, they go to echo or something else, but you just look at the derived electrocardiogram and everything is perfectly pristine. So you don't need to go do that echo. It's just an example of how there's medical savings. These techniques, we also pick up things like one observation, we haven't published it yet, a huge percentage of the patients that go into emergency departments with chest pain that are ruled out for ACS and they're sent out, they actually have a fairly high degree of what we call left ventricular electrical remodeling. It may not manifest as quote unquote LVH by voltage on the conventional ECG, but it's clearly remodeling there going on by the vectorcardiogram. So I think there's an entire group of patients that I would call left ventricular electrical remodeling chest pain that's costing the medical industry billions of dollars per year because we just don't know, what we're looking at. And the reason is we're limited by just this conventional ECG, which one can think of as kind of like one sectional slice. Why look at one sectional slice when we can look at the entire vectors that are in the background that create that sectional slice when you just view things in 2 dimensions.
So it seems like there's a lot to learn beyond that which meets the eye.
Yes.
Yeah, I have a question. So you had a list of all the techniques that were available in the software package.
Yes.
Just a little bit curious. I don't have that much experience of ECG besides being a medical student, but it seems to me that most of what you're doing is like basic signal processing.
Yes.
So which of these techniques did you come up with? Or which techniques did you come up with and you collected?
Sure.
Into a nice package?
Yeah, it's a mishmash. We have I have 6 or 7 patents in the area, most of which are already obsolete because then we find something new that supersedes it. But so for example, a lot of the HF-QRS is our own. The QT variability is kind of half me, but more so a collaborator from Slovenia who's been working on it for 25 years. and I helped him with the patent on that. The vectorcardiograph stuff is just 1950s literature, digging it up, figuring out what was useful then. So that's all public domain. It's been done for many years, but it's just coming back. What was old is new again. The T-wave complexity stuff is mostly public domain. There are certain ways of analyzing it that people have patented, including ourselves. But so the vast majority of what's in here is public domain. A couple patented things, and then sort of more trade secret-y, but published. A lot of it's just published anyway. So, but it's a mishmash of people.
The big challenge seems to be that nobody
Integration.
has put it all into the same integrated, comprehensive software suite.
You typically have a research group, and this is their pet parameter or set of parameters, and it's one technique. And then everything revolves around that one technique for prediction of this and prediction of that. But they don't know what else is going on in all the other labs. And so that was sort of what we were trying to do, is get this all integrated so it can be really clinically useful in big data.
I understand the problem.
Yeah.
But so how big is this your software package? Is it used extensively throughout like the US or?
Right. No. Right now, what I'm doing in this business is it's essentially a cloud-based business where clinicians who are using this upload their files in a HIPAA-compliant server, protected server. I get the raw data files, I convert them, I analyze them, I produce a report. Could have shown you some example reports, but the reports will show you like a three-dimensional linear discriminant and all the results of the scores, and then the results from the most salient parameters. And then it will tell you disease, no disease, if disease, what type of disease is most likely, show you the dot in space. So that's the product of the company right now. But I'm going to reach a saturation point. I'm doing all the analyses right now because I have enough time. But we'll reach saturation point where I'll need to, Martin and I have been talking about this, maybe assign or have someone at each institution who is like the A-ECG guy, so it's a matter of loading software here, training, and so forth. So there are different models of the way that we would try to move this forward. But for right now, it's a cloud-based business.
I see.
Yeah.
Okay.
And part of that's quality control because I do have to have eyeballs on with every file. It's not perfectly automatable, and the reason is there will never be a perfect program that detects all the fiducial points perfectly. Okay? You'll miss a P or a QRS end or beginning, or it'll be off slightly. So about 10% of files, I have to permute the settings a little bit to get the correct fiducials, so we avoid the whole garbage in, garbage out phenomenon. So it's not ready to be put into the hands of Joe clinician in terms of the analysis right now. It's just too much. Yeah.
Then again, Joe clinician does not interpret chest CTs.
Right.
That's the radiologist that has
Right.
the specialized chest CT software and reads and provides a qualified report.
Right.
It's just a question of we need to go from let's say there are more radiologists that have proficiency in reading chest CTs than there are Todd Schlegels in the world, because there's only
Right.
one. So it's time to start ramping this up.
How much do you charge for it?
It's cheap. It's relative. I have to go to my own site and look at it. I made it country specific as well. So if you're in the third world, it's almost nothing. But it depends on. It's also a little bit more expensive if I'm looking at a full-blown 5-minute high-fidelity ECG versus a 10-second snapshot. The price varies also based on whether I'm giving you a nice 5-page report for the individual patient that's very patient-centered, personalized medicine, or if I've got 100 of your patients and I'm giving you spreadsheet results without all the nice pretty pictures and so forth. But in general, somewhere I think it's priced about $40 to $60 US per patient, somewhere.
And in the scientific work, that's purely collaborative.
Yeah.
Yeah.
So I have from my perspective, if I'm collaborating with scientists who are contributing data that helps the system, the database is nice in that it's iterative. So each new piece of data that comes in that has good clinical imaging with it, essentially, goes into the database. And so let's say I need more ARVC cases right now, and I do. Okay? So if a collaborator says, I want you to help me with identifying ARVC by the advanced ECG, I'll say, great, I'll analyze those files for free because that's going to make a big contribution. I don't need any more healthy subjects. I've got a couple thousand. So it really depends on what's coming at me as to what the advantage is and how much time I have to spend for what I get back. But very often I do the collaborations for free.
I assume that some of the values are being influenced by the autonomic nervous system.
Yes.
How reproducible are
Yes.
the values that you get in different situations?
Great question.
I mean, that's at the emergency department. All patients
Yes.
are kind of afraid or
Yes.
because of the
Yes.
stress.
We've looked at that. We have, it's just a conference proceedings paper. And we looked at all the major ones and their reproducibility. Unfortunately, so far only in healthy subjects. So we looked at month to month and year to year reproducibility of all these parameters in healthy subjects. And we also looked at the effect of posture just to see if we had a seated reporting, is that going to change things as well? And so we know which ones are most reproducible and which ones are not. And as you noted, several of them are affected by autonomic nervous system. Certainly QT interval variability, heart rate variability. So if you're changing postures, if you come back and you've just had a big meal versus having been fasting, or different time of day, circadian rhythms, those things are more likely to move and they're less reproducible. Other things like the spatial QST angles, most of the things from electrocardiography, they're pretty stable as a rock through all of that. So we have a pretty good feel, but only have a conference publication on reproducibility. We do have a publication on that for just HFQRS, and more comprehensive. But for all the rest, they're just in the conference pub.
And you can still distinguish between healthy and
Yes. Yeah, for example, in the conference proceedings pub, we looked at whether or not it would have changed the disease call from the advanced ECG score for disease. And in no case was it changed, a month later or a year later. So even in those borderline cases. So the end result was, the score is pretty reproducible. Depends on what's in the score. Some of the scores that contain HRV or QTV are less reproducible, but the scores that you can get from a 10-second snapshot where you're not looking at the variability, those are pretty stable.
Okay, I think we've reached a conclusion, and thank you all for coming, and thanks once again, Todd.
My fixer sometimes it is very sensitive. If I
Yeah.
hold the click a bit too long, it goes 3 or 4 slides.
That's weird.